This is part 5 of our Pediatric Neurologic Disorders lecture, and we're going to start by covering our last few structural defects. We're going to start with cranial synastosis. This is a condition that involves premature closure of the cranial sutures, and this then inhibits brain growth. So typically, infants and young children have open cranial sutures. This allows for adequate brain growth, and these sutures do not fully close until late in childhood. Some children who have cranial synastosis experience closure of one suture, or they may experience closure of multiple sutures. If they have multiple sutures that are closed, their condition is often much more severe. If they only have one suture that's closed, it might just be a cosmetic defect, but not really inhibiting their brain growth. Cranial synastosis can result in hydrocephalus and increased intracranial pressure because the volume of the cranial vault is restricted. The child may have an underlying genetic disorder. The condition may be evident at birth, and we may see prominent bony ridges where the sutures are already fused, where we typically would feel a small gap or opening between the sutures at that point. Or craniosynostosis may present in infancy and toddlerhood with a smaller than expected OFC. So this again is why it's so important to measure head circumference up until 3 years of age to help monitor for this condition as well. Children with cranial synastosis typically have a great prognosis unless they have an underlying genetic disorder that may impact their cognitive development. Otherwise, with surgical intervention, children have great outcomes. Therapeutic management involves skull x-rays, which will reveal the fused sutures, and then surgical intervention, as I mentioned, to relieve the fusion. Nursing management postoperatively involves monitoring hemoglobin and hematocrit. There can be large blood losses during this procedure. Assess for pain in the child, especially in a young infant who is unable to communicate verbally their pain. Monitor for complications of the procedure, which include hemorrhage, fever, infection, and swelling. Also note that significant facial swelling may be present, and this can be distressing for family members, so make sure to provide family with education preoperatively and then reinforce that education postoperatively that the facial swelling is temporary and that it will reside or resolve at some point. The child may be unable to open their eyes, so encourage the parent to interact with the child and talk to the child to bring them comfort. Our final structural defect for the neurologic system is positional plagiocephaly. This is asymmetry in head shape due to external pressure on the developing skull. The Back to Sleep campaign was started to help reduce the incidence of sudden infant death syndrome, and it encourages that all children are placed on their back on a firm, flat surface to sleep for naps and for nighttime, which has really helped to lower the rate of SIDS, but unfortunately has increased the incidence of positional plagiocephaly. This is due to long periods of pressure applied to the back of the child's skull during bedtime and naps, where previously many infants were positioned prone for sleep or side lying. Torticollis, a condition that causes tightness of the neck and limited neck range of motion, can exacerbate the condition because the child favors one side or likes to rest their head on one side because it's more comfortable, or they're unable to turn their head to the other side. Therapeutic management is often conservative. This involves changing the infant's position frequently, doing frequent tummy time, so having the child lay on their stomach supervised. Molding helmets, as seen in the image in the upper right corner, may be required, but they're often for cosmetic reasons. It helps to reshape the child's skull so that they don't have such a flat spot on the back of their head. If you talk to people who work in craniofacial surgery, oftentimes you'll hear them describe it to families as, if you think of your child as a 9 or 10-year-old and they hop out of the swimming pool and their hair is soaking wet and the back of their head is flat, is that going to bother you? Are you going to be self-conscious about that? Are they going to be self-conscious about that? And if the answer is yes, then maybe a molding helmet for cosmetic reasons might be important for that family. If it doesn't bother the family, it's not necessary. Skull x-rays may also be used to help rule out cranial synastosis in this condition as well. Nursing management involves parent education, position interesting objects away from the affected side, and this encourages the child to turn their head to look to the other side, rotate their position often when they're awake, and also rotate their feeding position. So whether mom is breastfeeding, make sure she's feeding on both breasts, rotating the position in which she's holding the child. And if the child's being bottle fed, many families prefer to hold the child in one of their arms. Make sure that they're rotating that position and holding them in both arms. Also limit car seat use to only when traveling in the vehicle. Encourage families not to have the child sleep in the car seat outside of the vehicle or sit in the car seat when they're out and about, because this again puts a lot of pressure on the back of their skull. Next, we're going to move into infectious disorders of the neurologic system. The main infectious disorder that we are going to talk about is bacterial meningitis. For pathophysiology, this is an infection of the meninges that surround the brain and spinal cord. It can cause serious long-term effects for pediatric patients, and these can include sensory deficits, brain damage, and possibly death. Bacterial meningitis may result as a secondary infection from an HEENT infection, such as an ear infection or a sinus infection, or it may result from injury or intervention to the neurological system. This could be from a skull fracture or from interventions such as a VP shunt or a cochlear implant. Therapeutic management requires immediate hospitalization. This is a fast-moving infection, and we need to treat it very quickly. The patient will undergo a lumbar puncture. There's an image in the upper right screen of how we might position a young patient for a lumbar puncture, and then where we are actually sampling that cerebral spinal fluid from. That lumbar puncture will show us if the patient has bacterial meningitis. They will have increased white blood cells in their CSF and increased protein. They will also have decreased glucose because bacteria feed on that glucose. With the blood cultures, we are looking for the causative agent. There may also be cultures done of the throat or of the nose or of other areas in the body, such as the urinary system, in order to try to find the site of the original infection that may have resulted in this secondary infection. Causative agents are listed in the box on the right side of your screen. The most common causative agent varies by age, but some of these include Streptococcus pneumoniae, Neisseria meningitidis, and Haemophilus influenza type B. Therapeutic management also includes IV antibiotic administration, and this is started very quickly after the blood cultures are taken. The patient may also require corticosteroids to help reduce inflammation of their neurologic system, and antipyretics are often given to help reduce fever. Nursing management for the patient with bacterial meningitis includes performing a physical exam. Infants may present in the epistotonic position, and that's the image in the upper right of your screen, and that's due to strong muscle spasming. We may also see a bulging fontanelle. The infant may be consolable when lying, but irritable when picked up. And we also inspect for a rash. Different causative agents of bacterial meningitis present with a characteristic rash. Older children may be able to report that they're experiencing neck pain, or they may have a positive Kernig or Brodzinski sign. In the image on the bottom right of your screen, A1 and A2 show how to perform the Kernig sign, and this is where the patient is unable to fully extend their leg, or the practitioner cannot passively extend the patient's leg due to pain. Brodzinski sign is B1 and B2, where when the neck is flexed, we see flexion of the hip and the knees as well due to severe neck stiffness. We also inspect older children for rash. Nursing interventions include initiating droplet precautions, monitoring for signs and symptoms of increased intracranial pressure, and monitoring for seizure activity, as well as initiating seizure precautions. Bacterial meningitis is highly contagious, so it is important to prevent the spread of infection through the use of droplet precautions in the hospital because the infection is transmitted by respiratory droplets. We may also need to utilize post-exposure prophylaxis and post-exposure immunization for any close contacts of the individual diagnosed with bacterial meningitis. Other forms of prevention for different types of bacterial meningitis include administration of antibiotics during labor for any mother who tests positive for group B streptococcus, as well as immunizations recommended for all children against Haemophilus influenza type B or Hib, and the pneumococcal conjugate vaccine 13, which helps to protect against 13 different strains of bacteria that can cause meningitis. Both of these vaccination series are started at 2 months of age. The meningococcal vaccination for A, C, W, and Y strains is started at 11 or 12 years of age, and a booster is given at 16 years of age. And the meningococcal serogroup B, or the Men-B immunization, is recommended for high-risk groups, such as young adults who are living in close quarters in dorms or residential halls, and this is recommended at the ages of 16 to 18 years. Next, we will discuss Rey Syndrome, which is not an infectious disorder itself, but it does result during a period of illness. This syndrome is most common in children under the age of 15 while they are recovering from another viral illness such as croup or influenza. It is triggered by the use of salicylate containing products such as aspirin during a viral infection. It results in rapid brain swelling, liver failure, and possibly death for the patient. Symptoms that the patient may present with include vomiting, change in mental status, lethargy, irritability, and hyperreflexia. The history that the patient reports will be positive for a viral illness and ingestion of salicylate-containing products during that viral illness. The best option for families is to prevent this syndrome through education. This is important because many products other than aspirin alone contain salicylates such as Pepto-Bismol and Alka-Seltzer, among many other cold and flu products. So it is very important to properly educate families about avoiding these products in their teenagers and in their young children. Next, we will start a discussion of trauma related to the pediatric neurologic system. Head trauma is a common cause of injury, disability, and death in the pediatric population. The most common mechanisms of injury include falls, and we are more concerned about the severity of injury if it is a fall from a high height versus an infant rolling off of a couch may not be as concerning as the infant falling from the height of a changing table. We also see motor vehicle accidents are a main cause of head trauma in pediatrics, as well as bicycle accidents, especially if the patient is not wearing a helmet, as well as non-accidental head trauma, which we will discuss in more depth later in this lecture. Consider why a pediatric patient may be more at risk for a head injury than an adult. Things to think about are the proportionately large head size in comparison to their body, as well as a high center of gravity, which makes it more likely that they will hit their head against something when they fall from a height or they are injured in a motor vehicle accident or a bicycle injury. We also see psychosocial factors such as their curiosity and high energy level, along with their immature motor development, which puts them at a greater risk for suffering from a head injury. Nursing management of the child with head trauma involves gathering a thorough health history, including asking whether the child lost consciousness at the time of injury or if there was any change in mental status, asking questions about the mechanism of injury, such as the height of the fall or the speed at which the patient was moving when they were injured, whether there was any vomiting at the time of injury or shortly thereafter, and how many episodes of vomiting there were, whether there was any seizure activity, whether the patient reported headache, vision changes, or any neck pain, either at the time of injury or now that they're presenting for care. Physical exam first includes assessing airway, breathing, and circulation immediately after the injury and as they are seeking care, followed up with a thorough neuro exam, and this includes assessing the patient's level of consciousness, their pupillary response, and noting any seizure activity. Diagnostic testing for the patient with head trauma may include a head and neck x-ray, a CT, or an MRI, and these tests are useful in determining the severity of the injury as well as the type of trauma that the patient suffered. Common types of head injuries in the pediatric population include various types of skull fracture, and these may or may not result in underlying tissue damage. Concussion, which is the most common type of head injury in pediatrics. This is a traumatic brain injury that results in the disruption of electrical activities in the brain. A brain contusion, which is bruising of the cerebral tissue. subdural hematoma, which is collection of blood between the dura and the cerebrum, versus an epidural hematoma, which is collection of blood outside of the dura, but still within the skull. For more information about each of these different types of head injuries, you can see Table 38.6 in your Rickey textbook. This slide outlines nursing care of the child with a mild to moderate head injury. You don't need to remember everything on this slide. It is taken from the Teaching Guidelines 38.2 in your Rickey textbook, but it's helpful to know some of the warning signs that you need to educate families about that they should be monitoring for at home. And this is a type of injury that you will commonly see in the pediatric population, so it's really helpful to have some of this information in your back pocket. A mild to moderate closed head injury is an injury where there was no penetrating injury to the brain. The child did not lose consciousness at the time of injury. They don't have any other injuries to their head or their body. They've been behaving normally, and they were healthy before the injury happened. So these types of mild to moderate head injuries can normally be cared for and observed for at home. We see this often if the patient suffers a concussion during a contact sport. Then we educate their families about how to monitor them while they're at home. You can see on the left side of your screen the information you need to instruct parents and caregivers about include having someone stay with the child for at least the first 24 hours, ready to take them to the hospital if they have some of the worrisome signs or symptoms on the right side of your screen. Waking the child every 2 to 4 hours to make sure that they're moving normally, they're able to wake up when you are attempting to rouse them, and they recognize their caregiver and their surroundings, they're oriented, and they respond appropriately. We also then instruct families to closely observe the child for several days following the injury to make sure that they are still behaving normally and not having any of these worrisome signs or symptoms. You can review the box in blue on the right side of your screen for some of the abnormal neurological signs and symptoms that we should be educating families about. They should be monitoring their child for these symptoms and then calling their medical provider or bringing the child to the ER if they start experiencing these symptoms. This slide outlines nursing care of the child with a severe head injury, such as a penetrating head injury or one in which the child lost consciousness or experienced significant changes in their level of consciousness. Initially, the child needs to be stabilized, and this involves maintaining their airway, their breathing, and their circulation. We also monitor their neurologic status closely so we can identify any signs and symptoms of a deteriorating neurologic status. It is important to prevent or cease any seizure activity that is already occurring and to initiate seizure precautions, to treat any other related bodily injuries the child experienced, to monitor for signs and symptoms of increased intracranial pressure, to maintain a quiet and restful environment. This helps to reduce stimulation for the child, to administer any pain medications or sedation as needed or as ordered, and then to monitor for complications, and these include hemorrhage, infection, cerebral edema, or brain herniation. And this will conclude part 5 of our Pediatric Neurologic Disorders lecture series. We will pick up part 6, our final part, discussing head injury prevention.